don't have to do anything much.
For the next session, Lakshmi is one of
मैं
the...
request everyone to keep your cameras in the center, मैम. जयदीप सर, आप भी आपका कैमरा
Yes.
everyone.
चलो
Yeah.
ठीक है, कर लिया.
Yes.
करना पड़ेगा. We can start by 8, ma'am. I'll give you the cue.
We are not live, right?
Not yet. नहीं,
मेरा और जयदीप का मैचिंग है, डॉक्टर गगन प्रिया एंड इराम का मैचिंग है, अल्पेश के साथ भी मैचिंग है.
आपका reverse है, coat and shirt is...
नहीं, वो ब्लर कर लिया हमने पीछे वाला.
Ma'am, we are live on Facebook, ma'am.
Okay.
Yeah.
Should we start?
Yes, sir. I'm
Yeah.
sharing the link here.
A very, very warm welcome to everybody who has joined for this very important meeting. So, this is a meeting organized by the Diabetes in Pregnancy Task Force Group of Endocrine Society of India. So, endocrinologists are the group of doctors who are specialized in hormone related disease, and diabetes is one of the most common hormone related problems, and out of which gestational diabetes or diabetes in pregnancy is very, very relevant because it's not only important for the mother, but also it has implications for both in short term as well as long term implication for the baby. So today we will be discussing a very important topic, with like trying to make sense of the numbers in diabetes in pregnancy. So we people often come that my blood glucose is within range, and why am I getting treated, or why is somebody even asking for insulin? So we will try to understand that over the next 30 minutes or so, and to discuss that we have a very, very interesting group of doctors who will definitely tell you and make you tell you in a very simple way why it's important to understand the numbers in pregnancy who are having diabetes or gestational diabetes. So Dr. Gagan Priya will be coordinating the session. She is the convener of the ESI pregnancy in diabetes in pregnancy task force group. She is a senior consultant in Fortis Hospital, Mohali. We also have Dr. Jaideep Khare with us. He is currently the professor and head of People's Medical College at Bhopal. He will also help us understand this very important, simple in a simple way, but very important numbers which are important in in somebody with diabetes and pregnancy. Dr. Alpesh Goel, one of the most brilliant endocrinologists in India, so he is super academic, and he will also, as he keeps on speaking, you will get to know that. Another very, very, he is currently assistant professor in associate professor in AIMS Bhopal, and we have Dr. Iram Nahid, another very brilliant endocrinologist who is working as an assistant professor in AIMS New Delhi. Welcome all of you, and very warm welcome once again to all the viewers who have joined for today's discussion. Over to Dr. Gagan for taking it forward.
Thank you, Dr. Saptrishi. I think it's our third session now on diabetes in pregnancy, and we have covered a few important issues in the past. And today will be most important: what is hyperglycemia in pregnancy? There's a Persian poet who said women represent half of the world and they give birth to the rest of the half of the world. So actually, women are forming the entire world. And it's very, very important that we take care of women's health, not just for their own, not just to improve the health of half of the world's population, but the entire population. And there are a lot of changes that happen during pregnancy, hormonal changes, metabolic changes, which are adaptations to, have ensure good growth of the baby in utero. But sometimes these become maladapted. And that's where trouble arises. Metabolic maladaptation causes these problems. So, gestational diabetes or diabetes in pregnancy is one such aspect that's really important. The prevalence of diabetes in pregnancy seems to be very high. If you look at international numbers, 1 in 6 women uh, usually have some form of hyperglycemia during pregnancy worldwide. And for India, possibly the number is 1 in every 4. That means 25%. So we'll have a discussion about these things. And sometimes numbers can be confusing. It's a number game. Abhi 90 bolna hai कि 95 bolna hai. But let's simplify this and understand from a lay perspective what it is. So Dr. Jaydeep, I'll begin with you. One, what exactly is gestational diabetes? Like, why does it happen? Typically, like, what are the changes that really increase a woman's risk of gestational diabetes?
True, ma'am. So, thank you for the kind introduction and setting the stage rolling. So, as we say that gestational diabetes, so something related to pregnancy. Generally, it happens because of the increase in the counter-regulatory hormones, which causes insulin resistance. And the placental lactogen is the most culprit hormone. Other hormones are also there, like progesterone, cortisol levels also increases. And sometimes what happens, sufficient amount of insulin is also not produced in the body. That also leads to relative insulin deficiency. And typically, if we have to talk about gestational diabetes, happens at diagnosed at the duration of around 20 weeks of gestation. It can happen earlier also, but typically it is found in that period. And it has to be managed properly. Otherwise, as you have told, that it can lead to several comorbidities to mother also and to the baby also. So, relative insulin deficiency and increase in the counter-regulatory hormones leads to insulin resistance and deficiency. This leads to hyperglycemia.
Yeah.
Thank
So
you, ma'am.
I think what I understand from you is that during pregnancy, there are certain changes which actually are, meant to increase the fuel delivery of energy to the fetus. But at times they really, the compensatory mechanisms fail and the counter-regulatory hormone becomes too much for the insulin to compromise for this. Dr. Alpesh, I'll coming to you. Now, gestational diabetes, of course, is the commonest form of diabetes during pregnancy, but we do have women who are going into pregnancy with pre-existing diabetes. We also assume there's a huge burden of undiagnosed diabetes, which we might pick up. So, what are the different types of diabetes that we encounter in our clinical practice? And typically, talking of GDM, is there a particular time period when it happens?
Thank you, ma'am. So, different forms of diabetes in pregnancy or hyperglycemia in pregnancy are known. So, we can broadly classify them into one, which is hyperglycemia, which is predating the onset of pregnancy. That is pre-existing diabetes, as you said. So, say a mother with type 1 or type 2 diabetes, she is known to have diabetes and she conceives. So, that is a pre-existing diabetes. But there is another form of hyperglycemia, which is recognized for the first time during pregnancy, and that we can broadly classify into one, a milder form, which is gestational diabetes, and a more severe form, which is overt diabetes in pregnancy. Now, earlier, these two entities were indistinguishable, but now we have understood that these are two different forms of hyperglycemia in pregnancy with different consequences. So it is also important for the clinician, because while women with gestational diabetes have milder hyperglycemia, they can often be managed with diet and lifestyle modification. But women with over diabetes in pregnancy, a majority of them are more likely to require pharmacotherapy.
Right. So, what we understand is that it's not all, like, everything is not all apples or all oranges. There are
Yeah.
a mixed bag, and we really need to identify which is which so that we can tailor treatment accordingly. Dr. Iram, we've been talking about hyperglycemia in pregnancy, and like Dr. Jaydeep said, there is risk to the mother as well as the child. So, what are the risks that occur with gestational diabetes? And like we also talked about pre-existing diabetes or overt diabetes, full-blown diabetes, are the risks higher in those women?
Yes, ma'am. So, as we already know, can have pre-existing diabetes or diabetes first time manifested during pregnancy. So, in case of pre-existing diabetes, if the female is having uncontrolled hyperglycemia before conception, ideally the HbA1c should be less than 6.5. But if it is higher, before conception. So these pregnant females are at higher risk of having congenital malformations in their babies, especially in the form of cardiac defects or neural tube defects or anencephaly. Also, these females are at higher risk of having diabetic retinopathy, diabetic kidney disease. So these are common in those who has pre-existing diabetes. But the females who develop gestational diabetes around 20 to 24 weeks of pregnancy, these females are having risk of preeclampsia, or you can say hypertension, which is diagnosed first time during pregnancy. They can have premature rupture of membrane, they can have preterm labor, or they can have obstructed labor. They can have high risk of having cesarean delivery. So in fetuses also, the fetus or the baby can have risk of having macrosomia, that they can have a large baby which are difficult to be delivered, leading to some complication like shoulder dystocia or instrumental delivery. And also these child are having risk of having hypoglycemia after birth, and hyperbilirubinemia can lead to ICU admissions. So these are the risks associated with diabetes with pregnancy.
Yeah. So I think just to emphasize again for the general audience, what Dr. Iram has mentioned is that earlier the blood glucose is high, and more higher the blood glucose is, more the risk. So women who have pre-existing diabetes and are uncontrolled or have high blood glucose values in the early pregnancy, they are at risk of birth defects. So birth defects can be, inside the heart, they can be in the brain, they can be the spinal cord. And the mothers also have a greater risk of diabetes related complications during pregnancy. The kidney disease or other complications, even the eye problems can worsen. So it's very important that women who have pre-existing diabetes, they should have better control beforehand. So they should meet their endocrinologist, get them optimized control before you plan a pregnancy. I think everybody would agree here that planned parenthood is the right approach in anybody who has a chronic illness. And then, of course, the ones who have gestational diabetes, even in them, the baby can grow larger in size. So we call them large for gestational age or macrosomic babies, and they can run into trouble later on. Like they can have problems during birth or immediately after birth, like a low blood sugar. They can be jaundice, which can go longer, or even breathing difficulties sometimes we can encounter. Thanks, Dr. Ram, for elaborating that. Dr. Jaydeep, now, normally I would want to diagnose pregnancy, diabetes before pregnancy, but most of our population doesn't even know at 50 years that they've had diabetes for the last 10 years. So, most guidelines say that high risk women should be screened at as soon as the pregnancy is confirmed. Like you've got to know that you are pregnant, you screen for diabetes. How do you do that, and what are the cutoffs we use at that age?
Very true, ma'am. So our Indian society has given DIPSI guidelines. So whenever the patient is coming for the first time, whether the patient is in fasting state or whether the patient has poha jalebi, which is very common this place, just half an hour before also, we should advise them to go for a OGTT kind of thing, that we give 75 gram of glucose. And then after 2 hours, we check the blood glucose levels. If it is more than 140, and less than 200, then it suggests that the person is at higher risk, and it is suggesting of GDM. And as our patients are mostly coming from the rural areas, so follow up is difficult. Whenever the patient has visited to us, whether it is first after 6 weeks or 7 weeks or 8 weeks, whenever the patient has visited, we should get the test done. And if it is normal, then again we should advise them that after 20, at the 20 to 24 weeks of gestation, you should get again repeat test done, because at that time there is maximum risk of developing GDM. And if it is again normal, very good. If it is not, then these patients should come to us. And if the patient blood glucose levels are on the higher side, and then we can ask them that again come in a week time or tomorrow, that we will get in fasting state, because several times they will say कि साहब अभी we have eaten just parathes and we have came, or poha jalebi and we have came, that's why it is on the higher side. So giving this news that your blood glucose levels on the higher side, we should not terrorize them, and ask them we can get it done tomorrow, in which fasting blood glucose levels, if it is more than 93, and after OGTT of first hour, if it is more than 153, and after 2 hours, if it is sorry 180, and after second hour, if it is more than 153, it is suggesting that you are having GDM. So these patients should then ideally come to us, or be seen by the endocrinologist, because right now endocrinologists are not everywhere. So if they are diagnosed at PSC, they should be referred to us for proper management. Over to you, ma'am.
Sure. So,
Thank
Dr.
you.
Alpesh, are there any alternate screenings in the first antenatal visit? Like we've talked about one criteria, but can we also use just a fasting glucose or HbA1c in the first trimester itself?
Yeah, so the basic premise of doing a first antenatal visit hyperglycemia screening was to look for any undiagnosed diabetes.
True,
So
true.
any fasting plasma glucose of more than 126, 2-hour postload of more than 200, or even a HbA1c of more than 6.5%, more than or equal to 6.5%, that can diagnose over diabetes. But what happened was that once you started to screen these women, you started to see women who had intermediate sort of hyperglycemia, which was now labeled as early gestational diabetes. So the criteria that are popular are known as WHO 2013 criteria, which essentially use the same thresholds that we use after 20 weeks of gestation. And the thresholds were told by Dr. Jaideep. So the thresholds are 92 to 125 milligram per DL for 0-hour glucose, more than or equal to 180 milligram per DL for 1-hour glucose, and for the 2-hour plasma glucose, it is 153 to 199 milligrams per DL.
Yeah. So here also, I think if the value is 126 and above, it's labeled as a full-blown overt diabetes.
Yeah,
And
it
if
will
it's in
be.
that mid, like intermediate range, we can use the term, early just GTM. And I think HbA1c is something we are still using in the first trimester, but not later down the line, because then we'll discuss that as we go along. So Dr. Alpesh, now let's say a woman has a normal screening at the first trimester. When do we screen the next time? Who should we screen? Should we screen every woman there? Like Dr. Jaideep mentioned, 24 weeks or so. So, what exactly is the time for that screening and how we screen?
uh, Even if the early antenatal screen was normal, that just tells us that she's not carrying any pre-existing diabetes or pre-existing dysglycemia, which can be harmful even in the initial weeks. But as Dr. Jadeep told, the effect of placental hormones will begin in the after 16 to 18 weeks. So a second trimester screening, typically after 20 weeks, typically at 24 to 28 weeks, is universally recommended for all pregnant women. So, all pregnant women should undergo a 75-gram oral glucose tolerance test. And for that time, there are many criteria, as Dr. Jadeep told. DIPSI criteria are there, the IAD-PhD criteria are there, and often there is a fight between science and pragmatism. But if some screening is better than no screening, that is the first principle. So the criteria may vary according to the type of center that you are in. At our center and in most international bodies, they recommend to use the IAD-PhD, or the International Association of Diabetes in Pregnancy Study Group criteria. And for this, we advise women to come fasting after the 8 to 12 hour fast. They should be consuming normal diet in prior 3 days. And then we ask them to submit a venous plasma glucose sample at around 8 to 10 a.m. in morning. Then consume 75 grams anhydrous glucose dissolved in about 200 to 300 ml of water over 5 to 10 minutes. Beginning from the first sip of water, we ask them to submit a repeat sample at 1 hour and 2 hours. And we advise them not to do exercise or not to walk during the procedure, because that can lead to fallacious results. That's it.
Yeah, so I think the most well-studied criteria happens to be the International Association of Diabetes in Study Pregnancy Group. And just to, elaborate a little bit more, Dr. Alpesh, how were these criteria derived for the public, like for the information? Because many times, women come with My glucose is just on the borderline. Why am I being diagnosed with GDM? So can you elaborate on that a little?
So, for the general public, I would like to tell that any diagnostic criteria that we use have some biological uh, indicator. So, for these criteria, there was a large multi-center study which showed that a glucose level which is higher than these thresholds is associated with increased risk of adverse pregnancy outcomes that Dr. Iram had elaborated. So bringing glucose down to the below these levels is important, and that is why we diagnose women as having gestational diabetes when women meet these thresholds.
Yeah, so these are not just like, random cutoffs. They are based on large studies in a huge number of pregnant women, showing that risk above a particular level is higher for both the mother and the baby. So if you can bring it down, we actually can improve pregnancy-related outcomes. Dr. Iram, now again, the same question, it's an extension of the same. So even women with mildly elevated blood glucose, we now know, the ones who have gestational diabetes, they are at increased risk themselves, and the child is also at increased risk. But now, let's say we have started treating them. Most gestational diabetes we manage with diet, exercise, first of all. Though, yes, the overt diabetes, I don't think any one of us sits and waits around for diet to take effect. We start with insulin. But at what cutoffs do you think that we should start thinking of adding some drugs? And of course, we'll take the drug discussion in a separate session altogether. But what are the cutoffs we'll use there?
So, ma'am, as you said, in most cases of gestational diabetes, around 75 to 85% of females can be managed on diet and lifestyle alone. So, if they are having mild hyperglycemia, not in the overt range, they should ideally first be following the diet and lifestyle modification for at least 1 to 2 weeks. After 1 to 2 weeks, meanwhile, we'll do the blood glucose monitoring, and we have to see the fasting blood glucose levels 1 hour post meal and the 2 hour post meal values. If these targets are beyond the limit, which are the fasting less than above 95 milligram per deciliter, or 1 hour postprandial above 140 milligram per deciliter, or 2 hour postprandial more than 120 milligram per dl. So if the ranges are beyond these targets, then after 1 to 2 weeks of lifestyle modification, we should think of adding some drugs in the form of insulin or other drugs which can we can like discuss later.
True. So I think the wait is not for like, don't send her away for 1 month. We need to call them back in 1 to 2 weeks because the time is ticking and every week is counting here. Dr. Alpesh, now the difficult question is like, there's a woman with type 1 diabetes on multiple insulin shots. There's a woman with gestational diabetes on the other extreme. So how often should we advise them to monitor their glucose at home? Like Dr. Aram talked about pre and postprandial values. So how often do you recommend or do you tailor the kind of monitoring per person?
Again, ma'am, you're very correct that it can never be one size fit all approach. It has to be tailored. It will depend on the severity of hyperglycemia, how patient is responding, how many risk factors she is carrying. So it all depends on the discussion with the patient and the endocrinologist. But if I tell you roughly, we use two basic approaches. Either we ask them to do a staggered kind of log, where they monitor blood glucose using a glucometer before and after breakfast on one day, before and after lunch on one day, and before and after dinner on the third day. And that gives us a fairly good idea of the glycemic patterns. And most importantly, we ask them to maintain a remarks column so that they could write any erratic value that can be explained, and so that any deviations are easier to understand, and there is no change in pharmacotherapy based on an erratic this thing. Another approach that sometimes we use is to ask the patients to do a before breakfast, after lunch, and after dinner, and this is alternate day basis. So it can be either, but the visit frequency is generally once in every 2 weeks. So it is not once in every 2 to 3 months that we will use for routine diabetes. It's pretty fast because the changes occur very fast, and we also need to tailor treatment very quickly because we have to monitor fetus also. So it is generally once every 2 weeks till 34 weeks, and subsequently we generally monitor once in every 1 week.
And what would be the targets for good control? Like when would you say it's okay, now you're well controlled?
Yeah, so most values are less than 95 to 100, I would say, pre-meal, 2 hour post-meal of less than 126, post-meal of less than 140 to 145. We should not chase each and every value. As I said, any one or two erratic values, most often patients will have some craving, and if they have noted it down, they had some function at their home, they couldn't exercise, they couldn't walk. So that those values are explainable. We should not be jumping to treatment changes so often. We should closely monitor the log, and at the baseline itself, telling them to maintain a proper log with a diary and remarks is very helpful.
Yeah, so that maintenance of logbook, I think, is the key. And if you're seeing trends that, very frequent values are going off target, you intensify the treatment. But if 90% of values are falling in target, it's pretty okay. Another extension to the same question, I've seen a lot of gynecologists, coming back, sending patients back with an HbA1c report in the third trimester. How do we interpret that, or we don't look at it?
HbA1c as such for gestational diabetes, I think it has no value in diagnosis or even monitoring. For patients with pre-existing diabetes, it could be useful to kind of monitor HbA1c at a more frequent interval than what we do in a non-pregnant individual. We can monitor it 4 to 6 weeks. It helps to reassure us that SMBG values which are falling in target and we are achieving the target. And B, it's been shown that an HbA1c target should be more stringent in pregnant women. It should be less than 6.5% and could go as low as less than 6% as pregnancy advances. So mainly in patients with pre-existing or over diabetes, where you are starting with starting HbA1c will be +6.
Yeah, so I think the starting values are more important. And then, of course, we are intensively monitoring during pregnancy, anyways. Dr. Jaydeep, now we've been talking of 1 hour post meal, 2 hour post meal, and pre meal values. So, between pre meal and post meal, which is more important? Let's say a woman has a limited resource, so she cannot do too many tests. Would you do pre meal or post meal? And between post meal, 1 or 2 hour?
Post meal are more important, as we have discussed that insulin resistance is the more important thing which is happening, and in between 1 hour and 2 hours not much differences are there, as but the recent meta-analysis by Dr. Deep Datta sir has shown that if 1 hour values are higher, then it increases the risk of large for gestational age and nothing else. But if it is lower, less than 120, then it increases the risk of preterm labor, and rest there is not much differences are there. So both, ideally both should be under control, but it depends, as Dr. Alpej was saying, sometimes we can ask them to check after 1 hour, sometimes we can ask them to check after 2 hours, and over the period of that those clustered readings should be within normal range.
True, true.
Thank
So
you.
we can use a mix and match kind of a
Mix
thing.
and match, yes. Thank
So it's more of a fashion statement.
you.
So, Ram, we now have a lot of CGM devices, the glucose monitoring systems that are available and pretty comprehensive. So, one, are there any advantages of it in pregnancy? Which women would you consider using the glucose monitoring systems?
So, ma'am, especially in case of pre-existing type 1 diabetes, the use of continuous glucose monitoring is more helpful because these patients are at having high risk of even hypoglycemias that we need to prevent. So, there are different targets in gestational diabetes and pre-existing type 1 diabetes. In pre-existing type 1 diabetes, mainly we have to see the three things, that is time in range, time above range, and time below range. So, the time in range is mainly taken in CGM is from 63 to 140 milligram per deciliter, and it should be above 70% of the time. And time below range also we have to keep in our target, that is below 63. can also be below 63 to below 54, or very low like below 54. So the time below range below should not be more than 5%, and time below very low range like below 54 should not be more than 1%, and also time above range, that is more than 140, it should not be more than 25% in case of type 1 diabetes. So especially to monitor hypoglycemia and to keep the time in range, CGM can be an additional method. It is even not a substitute for the blood glucose monitoring. It's give an add-on additional information. Similarly, for gestational diabetes, we have to keep more strict control because they are not at that much risk of hypoglycemia. So time in range in case of gestational diabetes or pre-existing type 2 diabetes should be taken slightly higher, that is more than 90%. And time below range is also same, it should be less than 5%, and time above range should be less than 5% in case of gestational diabetes.
True. So, what I think you've highlighted also is that the target glucose values are different from a non-pregnant population. Here, the target glucose is 63 to 140, while in non-pregnant population, we possibly use 70 to 180 as the target glucose range. Tighter control because obviously the glucose values really make a difference here. And yes, between type 1 and gestational diabetes, there'll be differences. In type 1, there is a more risk of low blood glucose attacks. So obviously you can relax your controls a little bit more. So we've talked a lot about glucose values. Going beyond that, because, diabetes, whether it is pre-existing, overt or gestational, it's not just about glucose. It's a metabolic disease. Weight is involved, blood pressure is involved. So Dr. Jaydeep, there's a lot of confusion often. Normally women are not aware of how much weight to gain during pregnancy. And by the time we pick up GDM, they've already gained 8 to 9 kilos. So what are the targets for weight gain during pregnancy?
It again varies from patient to patient according to the pre-pregnancy weight. And if the pre-pregnancy weight generally in type 1 diabetic population is they are very lean, less than 18, or so in that patients we can consider gain of 10 to 14 or 10 to 16 kgs is not bad. And if normal weight is there and diabetes is there, then around 8 to 12 kgs is not bad. But if the person is obese, and that depends what comorbidities patient is having, like if the just BMI is on the higher side, or if the patient is also having dyslipidemia or hypertension, then it varies from 4 to 8 kgs also is not bad over the period of 9 months of pregnancy. So ideally, these patients, those who are diabetic, they should consult endocrinologist also, along with consulting the gynecologist, that what should be the ideal weight gain which should be happening to them during the period of pregnancy.
True.
Thank
So
you, ma'am.
it's not like one size fits all.
That's fine. Yes, true,
And
ma'am.
don't eat for two. I think this we discussed in the last session. Dr. Saptrishi had an interesting discussion there. So, Dr. Iram, again, some of these women tend to also have high blood pressure during pregnancy. So, what are the targets for blood pressure control in them?
So, as you rightly say, it's not just about diabetes, it's about a metabolic diseases. So, for it at every visit, there should be blood pressure monitoring also, and especially after 20 weeks of pregnancy, they should have routinely monitored their blood pressure. And if on more than two occasions, if blood pressure is more than 140 by 90 millimeter of mercury, these patients are said to have gestational hypertension also, and they should be started on drugs or any medication so as to keep below 140 by 90 millimeter of mercury.
So yeah, so we need to keep a track of that as well in every clinical visit and interaction. Dr. Alpesh, what are the other tests you would like to do in these women?
For women with gestational diabetes, I think apart from their routine antenatal follow-ups, where you would have routine blood pressure, body weight monitoring, you'd also want to look at fetal scans, especially after in the second half of pregnancy, because that's a time you expect hyperglycemia, if it is uncontrolled, to manifest with fetal microsomia. So you look at fetal scans. As endocrinologists, we always look at the scans, see what is the estimated fetal weight centiles, where are they going, abdominal circumference centiles. These are two very important parameters that we should look. If they are more than 75, more than 90 centile, then they indicate fetal overgrowth, and then you need to look at glycemic control and also weight gain, because free fatty acids can also act as substrate for fetal overgrowth. So those two things are very important. On the other hand, if the weight centiles are going towards the lower end, less than 10 centile, then this could be an over treatment, or patient could be restricting their calories. That is also not very uncommon in our part of country. In order to avoid insulin, women may often restrict their calories, and it is important to explain to them that they require some amount of calories, which is minimum. Generally, we take 1600 to 1800 kilocalories in pregnancy as the minimum. And because that can, if they are restricting their calories, then that can lead to IUGR and impaired brain development for the fetus. So fetal growth scans are important. But from gestational diabetes perspective, you don't need to monitor for vascular complications, because you know that it is milder form of hyperglycemia, which has given onset during pregnancy itself. But as for pre-existing diabetes or over diabetes, I think we should screen for kidney disease and retinopathy once in the first trimester of pregnancy. If it is normal, then again in third trimester and in postpartum. But if you are seeing any baseline abnormality, then possibly it should be done in every trimester of pregnancy, because during pregnancy there is a risk of progression of these vascular complications.
True. So I think both the mother's monitoring of certain things and the baby's monitoring of growth and other parameters is important. So I think we've had a very, very interesting session and discussion. At the end, maybe a fun closing remark from all of us. Dr. Jaydeep, we'll start with you.
So pregnancy is like a 2020 match. Aggressive, calculated approach should be done so that the well-being for mother and fetus is there, and that's all. And ideally, they should follow up with the correct doctors. If the diabetes is there, endocrinologist should be taken into account.
True.
Over to you.
Dr. Iram, your message.
Discipline is very important. Discipline in what you eat, discipline in following the advice of your doctor, and discipline in all the monitoring parameter. That is very important for management.
Yeah, so discipline for diabetes. And Dr. Alpesh.
I think hyperglycemia in pregnancy is very common. All pregnant women should be screened for hyperglycemia in pregnancy. It should be universal, and they most of them, they require a careful clinical advice. Endocrinologists are good persons to do that, and they can be managed for improving their, not only their well-being, but also the fetal well-being. And the care does not stop after the delivery; it actually continues even after delivery in postpartum. I hope we will discuss these in more details.
True, true. I think the next sessions we will cover each of these aspects. So before I hand back to Dr. Saptrishi, we began with, saying that women form half the world and give rise to the rest of the world. I think this is a very famous and one of my favorite quotes from Michelle Obama. She says, communities and countries are as strong ultimately as the health of their women. So we have to focus on that women health. So back to you, Dr. Saptrishi, to wind this session.
Thank you, Dr. Gagan. Thank you, Dr. Alpesh, Dr. Jaideep, Dr. Iram. It was a very, very informative session. So this videos do stay in ESI website. So if you have joined us live, we are really, really grateful for connecting with us. Hope this discussion is going to help you. And if you have missed it, and if you are watching it later, then also I think there are some very important messages that don't get confused with the numbers of like non-pregnant diabetes and diabetes in pregnancy are totally two different entities. So the numbers don't match, the lab ranges don't match, don't go into a false sense of complacency. If your blood glucose or HbA1c value is apparently showing normal, even for thyroid also it's partly true that even if it's apparently normal, it might not be that normal, and you might need to consult your gynecologist, and if it's more complicated, the endocrinologist. Thank you once again for connecting with us. We usually do this Facebook live programs once every month usually the third Wednesday of every month between 8 to 8:30. Please join us once again when we go live next month. And Happy New Year, a very happy Christmas to all of you, and take care and have a wonderful time and year ahead.
Thank
Thank
you. Happy New
you.
Year,
Thank you.
everybody.
Happy New Year. Thank you.
New Year.